Good morning. A very good morning to all of the participants who are joining here today. Today is fifth day, and today we are covering pediatrics nutrition and its importance at the current scenario. Dr. P.R.Jayakumar, he is a pioneer in this field. He is having MBBS, DCH, DND, MNAMS, MPhil in behavioral medicine, and he is a research scholar in our School of Behavioral Science department. His PhD is going to submit in this area. So he is also a senior consultant in Neonatology department, Govt.Medical College, Kottayam. He's an active person in the field of research and rehabilitation, especially the disability area. School of Behavioral Sciences is a pioneer institute imparting research and disability rehabilitation. Hence, he is a person who is very apt to today's class. I welcome in the name of all of who are joined here at IUCDS and in University. I welcome Dr. Jayakumar to present today's topic. So welcome.
Yeah, it's okay.
Good morning, all. At the outset, I extend my sincere thanks and gratitude to Dr. Babiraj sir, Director, IUCDS, and Dr. Hannah, and Mr. Rajesh, the organizers of this program, for giving me the opportunity to present before you this very important topic related to pediatric nutrition. And the pediatric nutrition is very important in the sense that it deals with the various phases of development of and growth of human being. And rapid growth occurs during the intrauterine period, neonatal period, infancy, and adolescent period. And most important thing related to pediatric nutrition is that the brain development occurs in the early phase of rapid growth during the intrauterine period and also during the period of infancy. More than 90% of the brain development occurs during this phase of growth. And the another important phase of human growth is adolescent period, where in addition to the somatic growth, there occurs sexual maturation and sexual growth. And linear growth and all types of growths are usually coming to a cessation after the age of 18 years for girls and 21 years for boys. And thereafter, there is only regeneration and some kind of replenishments over the rest of the period of human course of life. So with this small introduction, we may go to the topic of pediatric nutrition. And the most important thing related to pediatric nutrition is that the early phase, it is mainly depending on human breast milk. So, and we are not concerned about preterm feeding because generally birth occurs to us after 39 or 40 weeks of gestation, and at the time of birth, the weight of the baby is usually on the average 3 kg. But occasionally premature or preterm death occurs. And if it is occurring before 37 completed weeks of gestation, we call it preterm delivery. And because of advances in the development of preterm care, many of these babies are surviving. And many of these babies are surviving because of the special care we are giving for these babies. The most important component of this phase is preterm nutrition. And we should know some certain factors related to preterm nutrition in this scenario. And as all of us know, there is maturation of many organ systems is not completed or on the phase of early development. So the maturity of the immune system, maturity of the gastrointestinal system, maturity of the brain, maturity of the lungs, kidneys. This is a common feature for all preterm babies, especially so the lower gestational age. So because of immaturity of the brain, these babies are not in a position to actively suck, giving sufficient negative pressure to suck in breast milk. And there is no coordination of swallowing and breathing. So we have to depend on other methods of administration of the nutrients for these babies. So for purpose of classification, we are classifying these preterm babies into less than 37 weeks of gestation, between 34 and 36 weeks of gestation, late preterm, 32 to 33 weeks of gestation, early preterm, 28 to 31 weeks of very preterm, and less than 28 weeks of gestation, extreme preterm. Even those babies who are more than 22 or 23 are even surviving, even though the percentage of survival is less for these babies. So we have to be concerned about the feeding of these babies, and depending on the weight band, we can be classified those between 2.5 kg and 3 kg, and between 1.5 kg and 2.5 kg, and 1 kg and 1.5 kg, less than 1 kg, extreme low birth weight. So for extreme low birth weight and the extreme preterm babies, we have to depend on total parenteral nutrition. So we are giving intravenously all the nutrients needed for them. Sometimes it may not be possible to give all the nutrients needed for these babies through the peripheral veins. Then we have to go in for central veins, and we have to give dextrose, we have to give amino acids, we have to give lipids through these methods. That method is known as total parenteral nutrition. And partial parenteral nutrition, usually we are giving dextrose and amino acid only. And later, after some time, when these babies are gaining weight, and we start giving through these feeds through nasogastric or orogastric tube, and usually it is being given through using the gravity methods. And when the babies are becoming more mature, some swallowing and other abilities are attained, then we go for pallida feeding or spoon feeding. We are never using bottle feeding at any phase of development, giving nutrition for these babies. And the first choice is only for human breast milk. The colostrum is very, very important because of the bioactive substances which are present in the colostrum, and is giving a lot of immunity protection against infection for these babies. And express the breast milk, and if it is not possible, then we can have to give donor human milk through human milk banking. Now it is coming into practice in many of the centers here, even in Kerala. And sometimes we have to give fortification using human milk fortifiers to express breast milk. And the last choice is formula feeds, the artificial feeds. Term and preterm formula feeds are available, and the least animal milk. So this the procedure that we are following for expressing breast milk, and there should be some tactile stimulation for the mother, because the baby is separated. There is no stimulation for the mother, for the natural stimulation, for the production of hormones associated with the breast production and ejection, like prolactin and oxytocin. For that, we have to give soft touching over the back, then massaging all the quadrants of the breast, then the manual expression, starting from the base of the breast, using the thumb and with support below by the other fingers, and proceeding towards the nipple. And the expression that the maneuver is continuing repeatedly, so that there is expression of the entire breast milk, including the hind milk from the breast. The hind milk is very important because it contains more lipids, and it is highly essential for rapid growth and the brain growth of preterm babies. So, an alternatives which can be used for expressing breast milk are using breast pumps, maybe manual breast pump or electrically driven one, using negative pressure methods. And the collection in clean steel cups. It is steel cups are ideal, and can be used safely up to 6 hours after collection if kept covered in the room temperature, especially those who are going to the office and all. This method can be used, say, one or two times. The breast milk which are expressed can be kept even at ordinary temperature, can be kept for 6 hours and can be given to these babies. And in term babies also it can be given at the time when the mothers are going for office. And if it is kept in, the amount is more, and if it can be kept in refrigerator and can be used for even up to 24 hours. So human breast milk contains all the components for the growth of the newborn up to the age of 6 months. So that's why we are reaching for exclusive breastfeeding, and the breast milk is the ideal one for brain growth. So these are some of the factors related to preterm feeding. Because of the lack of maturation of oral feeding skills, we have to go for other methods, and that is a complex process of effective sucking, swallowing, and the coordination of suck, swallow, breathing, which develops by the age of 34 weeks of gestation. By that time, you can go for direct feeding and direct breastfeeding. So the order of steps that we are following are IV fluids plus nasogastric feeds, then nasogastric feeds plus pallida feeding. That is followed by non-nutritive sucking, then direct sucking plus pallida feeding, then full direct breastfeeding. These are the phases through which preterm babies are going for the methods of feeding for these babies. This is applicable to any human being who are not able to swallow, like in the case of elderly, or those who are having neurologic disabilities, pseudobarbar palsy, or swallowing difficulty due to other problems secondary to surgery, secondary to the metastasis due to carcinoma, other malignancies. All these conditions we can opt for this type of feeding. And for preterm feeding, initially we begin with the small volume because of the immaturity of the gastrointestinal tract. The babies may not be able to tolerate high volume feeds. So we start with low volume, then 1 ml into 3 hourly, intermittent over a period of 3 hours intervals initially, followed by more frequent feeds 2 hourly, then 1 hourly. Then gradually we increase the volume. Then again we reduce the frequency to 2 hourly till a volume of 180 ml per kilogram per day is reached. Then we can again reduce it to 2 hourly. Usually it is 2-3 hourly gaps. Direct breastfeeding is given to these babies. Night feeding is mandatory for all these babies, including term babies. And night feeding is more important in the initial phase of breastfeeding because of the increased production depends on night feeding, and the prolactin secretion is mainly depending on the night feeding. So there are some of the feeding problems which we can expect in these babies. There are feed intolerance, gastroesophageal reflux, some vomiting may be there. Then we have to reduce the volume and increase the frequency. We can temporarily stop feeding. Then the most dreaded complication associated with feeding, especially formula feeding, is necrotizing enterocolitis. This is specific for preterm babies. And of course, sepsis, because all newborn are generally immunocompromised, more so for preterm babies because of the immaturity of the immune system. Even though the passive antibodies transferred from the mother is giving some protection for term and healthy babies, it is not sufficient enough to give protection for preterm babies. So the requirement of preterm babies are a little more compared to the composition of the human breast milk. Sometimes these babies, even after giving sufficient volume, may not be able to gain weight. In that particular situation, we have to supplement more protein, especially up to 3.5 gram per kilogram per body weight has to be given. Usually in human breast milk, it is present in between 1 and 2 grams per kilogram body weight. And other micronutrient and vitamin supplementation has also to be given for these babies. And the most important components used for supplementation are vitamin D3, calcium and phosphate, vitamin A, B complex, and zinc, folic acid, and iron. Iron is started only late, after 2 or 3 weeks after birth. Fortification of expressed breast milk with the human milk fortifiers, which are available in the market, is also opted by physicians to meet the additional requirement of the above components, including protein, which facilitates growth of these babies. Now we are coming to, after achieving growth up to the age of 40 weeks, the preterm babies are more or less equal to that of term babies. Then exclusive breastfeeding, direct breastfeeding is enough for these babies. And exclusive breastfeeding is advised for all babies thereafter up to the age of 6 months of age. And we have to continue with the breastfeeding thereafter, but with additional, to meet the additional requirements, we have to give semi-solid and solid food. And first 6 months of age is having very rapid growth. All of us know that the birth weight, average birth weight is 3 kg. It doubles by the age of 4 months of postnatal age. And there is a movement in Kerala and all over India giving stress for exclusive breastfeeding, and that is termed Baby Friendly Hospital Initiative, BFHI. And most of the maternity hospitals are following the guidelines issued by this initiative. And the next phase is weaning. After 6 months of age, the breastfeeding itself is not enough for growth of infants. And also, we have to have a transformation of a liquid diet to solid diet. That's the basic idea behind the weaning. Not the substitution of one milk from human milk with another milk or adding another milk. That is the usual belief among parents, some of the parents. This has to be clarified, and we have to give the proper message for them. So it is a transformation from liquid diet to solid diet gradually, and we are giving semi-solid initial diet initially, food initially, like porridge, kurka, and this transformation occurs. All the mothers know about this, but along with this semi-solid, they are giving animal milk or formula sometimes. This is a bad trend, and that has to be discouraged. And we have to wean using cost-effective, locally available, and affordable, culturally acceptable, and mashable items, selected and prepared and given. One new item has to be added every 2 weeks, not too frequently initially. And try to input carbohydrate-rich all wheat or rice preparations, and protein-rich pulses and dal, and vegetables containing a lot of antioxidants, vitamins, fiber. So this is the ideal combination for the proper growth of these babies. Now, our objective after exclusive breastfeeding for the initial first 6 months of age, and thereafter continuing breastfeeding along with weaning, transformation of semi-solid to solid food, and by the age of 1 year, we have to achieve weight gain of 3 times that of birth weight, and a length of from 50 centimeter average to 75 centimeter, and brain growth from 37 centimeter to 47 centimeter. And there should not be any symptoms or signs of protein energy malnutrition, micronutrient deficiencies. This is our objective. And for finding out any error in the course of growth, we have to go in for monitoring. The monitoring of the under 5 children are being done, especially for infants, being done using growth chart. This is easily available in the immunization card issued by the Government of Kerala and also Government of India. So we can go in for using that, but even though it is present in many of the health cards, it is not being properly used. Serial plotting of weight, length, head circumference is mandatory, and thereby we will be able to diagnose many of the disorders in the early phase and can make intervention in the early phase so that there may not be any sequelae occurring. So if you are missing the early phase, we may not be able to compensate for that, and stunting and affection of the brain growth can occur. Because I already mentioned the fact that the most part of the brain growth is occurring during infancy. So these are some of the charts which are available. Weight for age, boys and girls, 0 to 5 years of WHO chart. Length, height for age, boys and girls, 0 to 5 years, WHO 2007 charts. And body mass index charts are not very essential for under 5 children, but head circumference is mandatory. I already mentioned about the brain growth. This is a reflection of brain growth. Also, it is helpful for the diagnosis of many abnormal conditions like hydrocephalus or degenerative conditions which is affecting the brain growth, leading to microcephaly. Can be diagnosed early. These are the two graphs which are primarily used in the for the preterm babies. It is from 22 weeks to 40 weeks to diagnose extrauterine growth restriction. There is another condition known as intrauterine growth restriction, which is usually diagnosed by using ultrasound examination of pregnant ladies. And if there is preterm deliveries, we have to serially chart the weight and height and head circumference of preterm babies. After giving proper feeding and all, we are taking weight, height, head circumference daily, weekly, and plotting these in this chart so that we can identify excited growth restriction. After 40 weeks of gestation, we can go in for the WHO chart 0 to 5. These are the charts. And on the x-axis and y-axis, we are having weight and age. So age in the bottom and the perpendicular, the weight is here. And there is an upper line and a lower line. So suppose we are taking the weight and height of normal babies. Only 3 babies will come in above the 97th centile. And only 3 babies will come below 33rd centile. So we consider them as highly abnormal. And less than 15th and more than 85th centile, they are taken as moderate, having moderate abnormalities. And the one between, this is the general principle for all growth charts, percentage, centile wise. Between 15th and the 85th centile, majority of normal babies are coming in this, and the median is 50th centile. So it is considered ideal. Serial plotting, and thereby there is a line going parallel to the middle line, is ideal one. And velocity of growth going parallel to the line, midline, is ideal. If it is coming down or going above, it is abnormal. So this is the general principle that we have to follow in interpreting, and even the layman can interpret this by using serial plotting of chart, which is easily available in the immunization card, which is not usually done. And if done, it is extremely useful. So we can yourself identify the early phase and take the baby to the doctors for consultation or nutritional specialist for consultation for correcting and giving early intervention. Whether it is related to faulty breastfeeding or whether it is related to weaning, effective weaning, or the feeding between 2 years and 5 years. So under 5 children, this graph can be used with maximum efficacy. So this is weight for age for boys, and this chart is weight for age for girls, and this is length or height for age boys. And if the length, this is mainly length or height is usually determined by the height and height of both mother and father, and genetically determined. But genetic potential may not be achieved if there is severe malnutrition that lead to stunting, which can be diagnosed early, and the early intervention can be done. That's the purpose of using this chart. Also, some of the hormonal deficiencies like hypopituitarism, growth hormone deficiency, can be diagnosed early from length or height for age charts. This is the chart that is usually used in Anganwadi, and serial plotting is mandatory. And the red area, it is the phase of severe malnutrition. Yellow area, moderate malnutrition, and green area is normal. Age-wise, up to the age of 5 years can be used. BMI chart are not very mandatory for under 5 children, but it is mandatory for adolescent age group. Head circumference, also already mentioned about the significance of head circumference. If there is severe malnutrition, it can affect the brain growth as well. Also, we can diagnose many conditions like heterocephalus and microcephaly, the early phase. Now we are coming to the growth monitoring. Above 5 years, up to the age of adolescence period, 19 years. And weight for age starts 5 to 10 years for boys and girls, WHO, and height for age 5 to 19 years for boys and girls, and body mass index for age 5 years to 19 years for boys and girls are easily available in the net, accessible in the WHO site. You can take the printout and use for the entire period from 5 years to 19 years. And IAP growth charts are Indian Academy of Pediatrics growth charts are also available. And adolescent growth spurt is a special feature, especially rapid growth occurring between the ages of 12 years and 16 years. Is the characteristic feature in this phase of development, growth and development. And peculiar feature of adolescent growth, besides the somatic growth, there is sexual maturation and sexual growth also. And a lot of hormonal changes are taking place. And under the influence of hormones, sexual growth as well as skeletal growth, rapid skeletal growth occurs. And linear growth is maximum during this phase. And it is a phase of, as already mentioned, increase to hormone production. So body mass index calculation is very important aspect for monitoring of adolescent growth, because genetically determined height and the weight according to the height is more important rather than weight alone, without taking into consideration the height. So we have to use body mass index for age charts, ideally for adolescent age group. And it is calculated by weight in kilogram divided by height in meter square. Suppose the height is 150 centimeter, we can convert it into 1.5 meters and can be multiplied again 1.5, and the weight is divided by that figure. That will give the body mass index. For adults, body mass index is usually less than 25 is considered normal and 23 is ideal, and above 25 is taken as overweight, and above 30 is taken as obesity. And for adolescent age group and older children, it is age dependent. That is why we are using the chart. For adults, there is no need of using the chart. It is a fixed value. So these are the WHO charts which can be used. Whatever charts you are using, you use the same chart, but the serial plotting is more important than using which chart for the purpose. Because any deviation from the normal occurring at any phase of growth is significant. And we have to make intervention, nutritional intervention during this period. And in adolescent age group, in Kerala especially, we are having two threats, two types of challenges are there. One is the problem of malnutrition, especially chronic, moderate and severe malnutrition, leading to underweight, stunting, and this is adversely affecting adolescent girls and boys. And on the other hand, even significant number of adolescent boys and girls are having overweight and obesity. This is a characteristic feature in Kerala. We are having both challenges undernutrition as well as overnutrition, and the problems associated with this, which can be diagnosed easily, the early phase, and proper interventions can be done in both cases: nutritional intervention, physical exercises, lifestyle modification, diet modifications. So it can be done, and we can easily identify the time when the intervention has to be done and it is to be continued, how long, and also a type of ultimately a behavioral modification, and which is extremely useful for the period of young adulthood and middle age. Many of the problems that we are facing at present, the young adults and middle age population, the early onset of many of the lifestyle diseases, the root cause is starting at the age of adolescent age. See, this is a BMI for age chart for girls. The basic principle is the same. While protein, if it is going upwards and this is above these lines, it is overweight, indicative of overweight or obesity, and if it is less, it is indicative of stunting or underweight or severe malnutrition. So far we have covered related to problems of monitoring and how monitoring can be done effectively, and how can decide it is going abnormal. Then we are looking for some of the abnormalities that I have mentioned this in this PowerPoint presentation. And starting from the intrauterine period, we have got intrauterine growth restriction. Those babies are likely to develop stunting. Those babies are likely to develop underweight later also. So catch-up growth can occur if there is proper intervention in the early phase. And already the graph related to that and identification of both intrauterine growth restriction and extrauterine growth restriction has been mentioned earlier. And the identification of severe acute malnutrition or SAM, the most important thing for the under 5 children. And the growth chart we can effectively use to identify that. If it is acute type, with the early intervention and emergency intervention is mandatory, because we have to admit the patient and give emergency treatments. But chronic phases of severe malnutrition, we can even home treatment is effective, and intervention can be done at home alone, but with under effective guidance and scientific guidance related to the nutrition of these babies. So these are some of the abnormal conditions associated with nutrition, nutrition, children and adolescents. Marasmus, primarily energy malnutrition, and kwashiorkor, primarily protein malnutrition, undernutrition. Marasmic kwashiorkor, combined protein energy malnutrition, and severe chronic malnutrition and stunting. It is present both in childhood and adolescence. In moderate chronic malnutrition, the incidence is very high, and mild malnutrition also can be diagnosed, and usually it's not a very serious problem. But at present we are having the other side, overweight and obesity, and also metabolic syndrome, polycystic ovarian disorder. The incidence is also increasing. And undernutrition, the incidence is usually between 20% and 30%, varying with the locations. And the overweight, obesity, and metabolic syndrome vary from 5 to 7%. So we are having both challenges. and we have to address both situations. And so far we are concerned with the major nutrient deficiencies: proteins, carbohydrate, and lipids. Now we are coming to, even though the weight, height, everything is normal, not always the babies or the adolescents are normal if they are having any of the conditions that we are going to mention in this. That is related to micronutrient deficiency disorders. This is due to specific deficiency of nutrients which are needed in small amounts. And that includes minerals, vitamins, and the major problems that we are having is iron deficiency, iodine deficiency, vitamin D3, vitamin C, vitamin A, folic acid, thiamine, pyridoxal phosphate, cobalamin, B12, riboflavin, nicotinic acid, vitamin K, especially in the newborn period, and certain other minerals, selenium. So iron deficiency is the incidence is very high, especially among adolescent girls. This has to be addressed well in advance because it may affect future fetus and children. So supplementation of iron is mandatory for all adolescent girls. So iron deficiency leads to microcytic hyperchromic anemia. This also affecting the brain function as well. And iodine deficiency was very rampant in our population previously. Now it has been, the incidence is low because of intervention using fortification of salt by iodization. So iodized salts are now being used by the population at large. That has led to the decreased incidence of iodine deficiency disorders. The most important aspect of iodine deficiency is not goiter, but intellectual disability to the newborn because of the deficiency, endemic deficiency of iodine in pregnant ladies. And vitamin D is another lifestyle disease rather than a nutritional disease because of lack of exposure to sunlight, leading to hypocalcemia, calcemia in the newborn period, and clinical rickets with manifestations of bony defects, and osteopenia and osteoporosis in older children, adolescents, and young adults, and even elderly. Early onset of osteoporosis and osteopenia occurring in all age groups is mainly due to the lifestyle, lack of exposure to sunlight, and because of the insufficiency or deficiency of vitamin D, lack of absorption of calcium from the gastrointestinal tract, even if it is present in sufficient amounts in our diet. This is a major problem that we are facing at present because of our improvement in the socioeconomic status. And the older generations were not having this problem because of sufficient exposure to sunlight. Because this vitamin D is not sufficiently available in the usual food, the diet which we are eating. That is a major problem. And the vitamin C is usually present in all green leafy vegetables, especially Indian gooseberry and all. But occasionally there can be deficiency leading to even skeletal deformities, gingivitis, and scurvy. Vitamin A is usually present in all vegetables, green leafy vegetables. But in severe malnutrition, especially the northern part of India, even now vitamin A deficiency is seen. It's mainly affecting the eyes, the vision, because we know that night blindness and cirrhosis conjunctival and cirrhosis cornea are associated with the vitamin A deficiency. And folic acid lead to anemia, deficiency of thiamine. This is most common in those who are addicted to alcohol and is not taking enough food. They are more likely to develop the thiamine deficiency and other neurotropic vitamins, leading to many neurologic manifestations like Wernicke's encephalopathy and even psychosis. And thiamine deficiency in children can lead to beriberi and cardiac failure. Pyridoxal phosphate deficiency is not that rare and is usually manifesting as convulsions or seizures in the newborn period. And vitamin B12 may lead to megaloblastic anemia and peripheral neuritis. Riboflavin is associated with angular chelosis and glossitis. Nicotinic acid deficiency lead to photodermatitis. The condition is known as pellagra. And vitamin K usually manifests in the newborn period as hemorrhagic disease of the newborn, early or late. That's why we are routinely giving vitamin K1 to all newborn. And selenium deficiency is associated with cardiomyopathy. These are some of the conditions. The list is not complete, but I am giving only those which are more common and more significant. So a lot of hundreds and thousands of micronutrient deficiencies are being reported in literature. So you can go through it, and more and more disorders are being identified. It is more so in genetically predisposed individuals rather than general population. So this is a picture of a baby having protein energy malnutrition. Mid upper arm circumference can be used as a screening test, but more useful, the better option is using growth chart. We can identify this more accurately using growth chart. This is a rough method usually used in Africa and other socio-economically low-income countries, and which is used if the mid upper arm circumference is less than 11.5, it is taken as severe malnutrition, indicative of severe malnutrition. So there is wasting, there is thinning and wasting. Severe, another example of severe acute malnutrition, SAM. This is a typical marasmus. Another type where the protein deficiency is more compared to energy deficiency, and the weight may not be that low compared to marasmus, but the neurologic manifestation and the dermatologic manifestations will be more, along with edema all over the body. And this is a kwashiorkor. The treatment of kwashiorkor is more difficult than that of marasmus because the appetites may be less. And in marasmus, appetitis is voracious and you can easily feed these babies. And the initial phase, the severe malnutrition, the initial phase we have to manage in the institution. And after stabilization, we can send these babies to home. Fortunately, the incidence of severe acute malnutrition is less in the state of Kerala. And this is not coming, the incidence is coming up because of the lifestyle changes, lack of exposure to sunlight. So vitamin D3 deficiency, this is a widening of the wrist, and there is a growing ends of the bones are distorted. There is cupping and fraying and irregularities in the growing ends of the bones, characteristic of rickets. Vitamin C can also present with bone manifestations. So this is due to vitamin C deficiency. Here, angular stomatitis is also seen. It is due to riboflavin deficiency. So this is due to multiple vitamin deficiencies, gingivitis and bleeding. This is pellagra, typical, where sunlight exposure, the skin areas exposed to sunlight be having severe dermatitis. This is due to the deficiency of nicotinic acid. This is quite common in Kerala also. This is due to essential fatty acid deficiency, and is known as phrynoderma. The rough skin and these lesions, the type of lesions that usually present in the XXR aspects. This is due to iodine deficiency, goiter, most important aspect related to goiter is not goiter itself, but intellectual disability that is likely to happen to the babies. If this adolescent girl is becoming the young adult and pregnant and giving birth to a child, the child is likely to develop intellectual disability due to iodine deficiency. Fortunately, we are able to overcome this by using fortification of salt with iodine. So we have already mentioned about the deficiency diseases due to proteins, carbohydrates, micronutrients, and all, an overview. Now we are also having the other side due to overnutrition or disproportionate nutrition. And still the incidence of undernutrition is more than that of overnutrition in our population, and we should not underestimate the undernutrition that is quite rampant in adolescent age group. So adolescent population is having the incidence of malnutrition, especially undernutrition, severe type of undernutrition, chronic undernutrition, between 20 to 30%. And for the overnutrition or the metabolic syndrome like presentation is usually between 5 to 7%. So we have to address this situation as well. And the metabolic syndrome is characterized by the presence of late childhood and adolescent obesity, the discolor, the hyperpigmentation of the skin, acanthosis nigricans. And if you are going for lipid profile, that will be the cholesterol, high density, low density lipoproteins, very low density lipoproteins, triglycerides, all will be elevated. And there will be insulin resistance and postprandial hypoglycemia due to the increased secretion of insulin due to the resistance. That's the early phase of diabetes mellitus, type 2 diabetes mellitus. Then there will be early onset of type 2 diabetes mellitus in this population. And in female, adolescent girls can develop infertility and polycystic ovarian disease. And there can be early onset of diabetes mellitus, type 2 diabetes mellitus, and hypertension, essential hypertension for this population. Usually, we are getting all these things after the age of 40 or 50, but when the adolescent girls or boys are having metabolic syndrome, they are likely to develop. Definitely, genetic contribution is there, but they are likely to develop it early. Type 2 diabetes mellitus, hypertension, coronary heart disease, and increased risk for cerebrovascular diseases, and higher risk for colonic and other cancers. So these are some of the challenges that we are having due to improvement in the socioeconomic conditions and change in behavior, dietary behavior. In fact, we were having a very good cultural background, having using high food materials which are rich in fiber, vitamins, minerals, antioxidants, and we are using food materials used by boiling rather than frying, and not using many other chemicals for the preparation of our diet, and using yogurt and curd and other naturally occurring probiotic and prebiotics in our diet. But we are now going in becoming modern and changing our lifestyle, healthy lifestyle in the diet. Culturally we were having, and we are going into the Western style, and that is leading to the metabolic syndrome. So there is one of the important aspects that we have to consider, and we need a behavioral change going back to our good cultural background. So this is the evolution of from a thin early phase going into the fungal obesity and overweight and obesity, and to the stage of metabolic syndrome, and leading to the early onset of many of the lifestyle diseases. And that is the end of the story. So what is the answer to this question? Already mentioned about the cultural background, where we were using a lot of green leafy vegetables and those the fruits and the fiber containing and antioxidant containing foods, and should come in the base of the pyramid rather than oily foods, high fat containing foods, then fried foods, and then it should come towards the end of towards the tip of the pyramid, the least we have to take occasionally only, and routinely we have to go in for this pyramid, and we have to opt for all grain, whether it is rice or wheat, because it contains a lot of vitamins, minerals. For example, if we are using the wheat, and if we are going in for maida, a lot of uh, dietary content is lost. Such a problem that we are facing at present. And the all grain contains minerals, vitamins. Parboiled rice contains minerals, vitamins, and all. So that is culturally more appropriate and also scientifically more appropriate for us. Instead, we are going for the Western style. So we have to include as our older, father, mother, and grandmother and father were doing, going for a lot, using a lot of vegetables and fiber containing, antioxidant containing food materials, and fish and other items can be included. And the method of cooking is also important, and boiling and using these food materials in that manner is more useful. And this is the ideal one for us, the selection of our food. This is our food plate, and only 1/4 or even less than that should contain the fat-rich food, and the all grains should be used rather than the refined one. A lot of colored things contains a lot of antioxidants. The antioxidants are important because of the fact that they are giving some protection against many of the lifestyle diseases and cancers. So thank you all for patient hearing, and now this is the time for interaction related to the topic, and not only for the pediatric nutrition alone, but extending to the adult nutrition and even geriatric nutrition. And in specific situations where we are having a lot of disability, disabilities related to feeding, there are conditions, neurologic conditions, in which the individuals may not be able to take in food the usual way. Then we have to opt for alternative methods. So to summarize what we have done related to the pediatric nutrition, the most important aspects I stress is the rapid brain growth period during the intrauterine life, and the intrauterine fetal development is very much dependent on the adolescent girl and young adult, young lady which is going to become pregnant. Already mentioned about the adolescent importance of adolescent nutrition, the interventions related to adolescents to prevent both overnutrition, obesity, metabolic syndrome, and to prevent undernutrition, stunting, chronic, moderate and severe malnutrition, leading to thinning and wasting. And also prevention of iron deficiency, iodine deficiency, and other micronutrient deficiency. Then the intrauterine growth restriction can be prevented to a greater extent, and the brain development starts from there, and intellectual development of the future newborn and infant and child and young adult depends greatly on this. And the related specific problems related to preterm feeding, then related to the advantages of breastfeeding, advantages of breast milk, how breast milk is giving protection. Breast milk contains a lot of bioactive substances, antibodies, cells, which are probiotics and prebiotics, which are helpful in the prevention of many infectious diseases and promotion of brain growth because of the high content of lipids, helpful for the myelination and multiplication, myelination and the development of neurons, like docosahexaenoic acid, DHA, essential fatty acids present in breast milk. And up to the age of 6 months, breast milk is ideal one, and we have to promote breast milk alone. And after that 6 months, proper weaning is mandatory, and proper weaning is highly mandatory for the somatic growth as well as for the brain growth. And the idea behind weaning is transformation from semi-solid to solid diet rather than substitution of or addition of one milk with another milk. And from 2 years to 10 years, the growth is, the velocity is slow. During that period also, we have to concentrate by using the growth chart. 0 to 5 years chart, WHO chart is available, and we are usually following that chart. Then 5 years to 19 years, the growth charts of the WHO and the IAP charts are available, which can be used. And the 0 to 5 charts are routinely being used in Anganwadi, and at home also by parents it can be plotted and monitored, and they can identify anything that is any flattering of the curve and get the advice from the dietary specialist, physicians, pediatricians, or general consultants, so that early intervention can be done. The correction in the diet can be done. Then I mentioned about the rapid growth that is occurring during infancy. Then another phase of rapid growth, the adolescent age group, especially from 12 years to 16 years, where sexual development is also occurring. And the requirement is a requirement of diet for the macronutrients and micronutrients are more, even equal to or more than that of the adult in the adolescent age group. Not depending on the size of the adolescent, but that is more than the adult requirements for these adolescents. So there is a misconception for parents that they need diet according to their size, present size, because they are more active, they are having rapid growth, and if we are not giving proper nutrients, both macronutrients and macronutrients during this phase of development, they are likely to miss the chance, because after 18 years or 21 years, for girls and boys, if you are giving additional diet and excess diet, it is not going to compensate for it. Missed the opportunities. And instead, if you are giving more food after the age of 20 or 21 years or 25 years, you are, there is no additional benefit out of that. They are going to develop obesity. So the growth is not in the linear fashion, but in the transverse fashion. That is going to occur if you are giving food, additional food for the young adults. So the best opportunity is the phase where there is a rapid growth of bones and sexual maturation, sexual growth, and the hormonal influenced growth that is happening during the adolescent phase for both boys and girls, especially for girls, because iodine deficiency or iron deficiency or other micronutrient deficiency is going to affect the fetus, future fetus of these adolescent girls. That is the significance of adolescent nutrition. So, using growth chart is the vital part, and the monitoring using the growth chart all throughout from 0 to 19 years. Using either of the charts I mentioned is mandatory, and early identification of these nutritional disorders can be done, and the early interventions can be done so that sequelae can be avoided, morbidity and mortality can be reduced, and we can have a healthy newborn, healthy infant, healthy child, healthy adolescent, and a healthy population. And we can prevent many of the lifestyle diseases that we are facing at present. The start of which is the beginning of these disorders are not in the young adult period, but it is in the adolescent or even before that. I mentioned about the metabolic syndrome. Yeah, having because of overweight and obesity and associated problems. The early onset of many of the lifestyle diseases, which are contributing to morbidity and mortality in our population. So, hope that you are able to follow many of the aspects that covered in this short lecture. So, you can apply many of these methods for meeting the nutritional requirements of those who are having disabilities related to swallowing, related to secondary to neurologic disability, or those who are having terminal care, undergoing terminal care. Then you have to go in for tube feeding sometimes. For those who are having comfort care, following illnesses, malignancies, secondary to malignancies, or degenerative diseases, or age-related problems. So thank you all for patient hearing, and I am only happy to have some interaction with you. Any questions related to the topic? Open for discussion. I am.
So, thank you very much, Dr. Jayakumar, and now it is time for discussion.
Oh, please tell me about your opinion about keto diet as well as fasting. Now, related to the keto diet, it is not an ideal method for treating overweight and obesity. Keto diet is being used as a therapeutic measure for the treatment of refractory seizures in children, and that is the only indication for keto diet. And intermittent fasting, it's if it is avoiding 1 or 2 feeds per day may be good. Otherwise, the entire day it may not be that useful. Some may be even harmful for the those who are having obesity. because I have mentioned about the metabolic syndrome. The major feature of metabolic syndrome is the insulin resistance that is developing, especially for adolescent girls and boys. Whether if they are going in for fasting, they are likely to develop problems related to hypoglycemia and the complications associated with that. Because in these population, the main problem is they are craving for food, and craving for food is associated with insulin resistance. After taking food, the insulin level will increase inappropriately. That will lead to hypoglycemia. While doing fasting blood sugar and postprandial blood sugar, in fact, the postprandial blood sugar is low. So they are very happy, and they will tell that I am having only this much sugar in my blood. And it's an ominous sign. So the fasting in these obese individuals may be disastrous. So keto diet is not advised as a method for treatment for obesity. Reducing the food, they have to reduce the frequency, and they can reduce the frequency and the volume gradually, so that there may not be any adverse events associated with this intervention. As far as related to the fasting on religious grounds, if in the initial few days there may be problems of hypoglycemia, but after that the body will adjust to the changed behavior, changed cycle, biological cycle, so that there may not be any increased production of insulin. So they are less likely to develop hypoglycemia. And they will get their energy from beta oxidation. That is leading to the ketone production.
Any more questions?
Hello, sir.
Yes.
If an adult is taking a keto diet, will there be any side effects in that?
Yes, definitely. A keto diet means you are taking increased amount of fat only, and
Yes.
reducing carbohydrates, and that is not advised. Therapeutic advice is not there for ketone diet. Ketone diet is only for refractory seizures, indicated only in refractory seizures.
Okay.
So,
Thank you, sir.
So hope the questions are over. Any more questions? Okay, I think today's session is the doubts. Okay. Yes. Yeah. So hope today's session is worthy for all of you. And now I invite our honorary director, Dr. P.T. Babra sir is here to say a few words about this whole session and interact with you in this regard. Before that, I have to inform you that I will publish the list of participants who submitted the assignments. Today, I will publish it in the classroom, or I'll send a note to classroom, Google, WhatsApp also, so that you can check your name, and if you are not submitted, then you can submit it into the classroom. Please take care of that, because only to those who submitted all the assignments will be send the certificates. So I invite Dr. Babra sir to say a few words.
here I am happy to say some words about Dr. Jayakumar. As I told you, Jayakumar sir is a pioneer in the field of pediatrics. Now he's working as a neonatologist in the Medical College Kottayam, Kerala. And he has a lot of experience during his periods of services. And again, since he is a committed person, he has joined his further study in medical field, that is rehabilitation medicine. And he joined for his PhD in this particular area. All these things shows his commitment to this field of medical services. Even after his retirement, he's still continuing his education and research in the field. Without research, no system will be updated. No nation can empower their manpower, especially in the field of medical field. Here, Dr. Jayakumar is a person, as I told you, is a really committed person in the field of medical science. The School of Neuroscience is a field imparting rehabilitation for the differently abled and training for the differently able. His contribution to the field through his research activities is something great. So today's class, I think you are all enjoyed very much. Sometimes this class is very speedy one because a lot of information have to be imparted, but during this particular time limit, he has to finish his job. So I think he can finish his job, and you are all enjoyed the classes. And again, once again, I convey my special thanks to Dr. Jayakumar in the name of God joined assembly here, and in the name of School of Beer Census, IUCDS, and in MG University, Kottayam. Thank you, sir. Thank you very much. Thank you.
So, thank you very much. Today there will be no more classes. Today the session is over. Tomorrow in the morning, 10 o'clock, our next session will be there. And I hope all can submit the assignments by today. I will share today's assignment also. Thank you very much, and see you in the WhatsApp group. I will ask permission to Dr. Jayakumar to be in the group for a day. Let me check whether if he is free, I will add him. Otherwise, I'll send the questions to him and we'll get the answers for you. Thank you very much. Am I audible? Hello?
Yes, ma'am.
Yeah, yes, ma'am.
Okay, bye. See you then.
Bye,
Okay,
ma'am.
ma'am. Thank you.
Okay, thank you.
Thank you. Thank you.
Thank you, ma'am.